the public wishing to speak on items not on tonight's agenda? Seeing none, I'll close the public comment and ask for any comments from board members. I'll just very quickly say thank you to June Ponce, to our foundation executive director. Thank you to everyone who helped put on the event on Saturday. It was great to see so many familiar faces throughout the city of Watsonville, and continue to build out that community buy-in into the hospital. You know, as we just heard, you know, this is a continuing process to make this hospital something that we all want it to be. And this last Saturday was a great step in the right direction, just to get ourselves back out there and let people know that this is a community-based hospital, that we're back out in the community, and that we would like to bring people back into the hospital, and that we're here to rebuild this hospital. So June, thank you so much for your team, everything that you did, and it was a great event. I've heard nothing but good things, so thank you for putting that on. With that, we'll move on to our consent calendar. We have, I believe, three items on today's consent calendar, and Rosie, if you could list off the items.
Yes, the first item is the minutes approval for August 28th, 2024 and September 12th, 2024. The second item is the policies and policy summary approval from September 2024. And the third item is the Colorado Valley Healthcare District Hospital Corporation Strategic Planning and Marketing Committee member appointments.
I'll ask now for the board, any questions for staff or of any of these items, please show.
And item 2, one of the policies covered, I'd like to take off the consent agenda for discussion later. Procedurally, I'll do that.
Would we need to pass a motion to take that off, or can I just take that off? And no,
You can just pull that, and then you vote on the rest of the items, and then you discuss those two, and then you vote on those.
okay. So I'll remove item number 2 from the consent agenda and put it into the discussion item. So that will be, you know, which
Are we removing the
It's a
whole
policy, it's the cath lab quality assurance policy.
one policy,
Just one
one
policy,
left,
one medical.
one alternate?
Correct. You
So, does
just-
that make sense?
Yes, you just remove the policy that Dr. Gallagher wants to discuss, and then the rest is up for motion on the consent.
Okay, so we'll talk about that policy after the consent agenda. So any other questions about the consent agenda for the board? Seeing none, do we have any public comment on the consent agenda tonight?
No raised hands online.
Any public comment for the consent agenda from the, seeing no raised hands, I will ask for a motion. Consent agenda items 1 through 3 without the cath lab quality assurance policy.
Move approval.
Second. Pimentel and Fox, thank you. Director Gallagher?
Yes.
Director Fontes?
Yes.
Director Pimentel?
Yes.
Director Cox? Yes. And Chair Menu?
Yes. All right, so Steve, if you could tee up the cath lab quality assurance policy and this. Sure, yeah, we can do that. Joe, if you could,
Sure. My concerns, there are many processes in the hospital for quality assurance. The medical staff has case reviews that go to SQ and MQRC. Each department also has its own performance improvement where they'll list a number of items for the year to try to improve performance. I understand the need for this quality assurance policy for the cath lab. My sense was it was really quite generic and lacked detail about what would be measured, what would be the criteria, what would be the cutoffs, what would be the actions taken. And so I think it needs sort of further development. I think it's too non-specific to actually function. I have had some background conversation by email with Tony and Steve and have put forward some of my thoughts about what needs to be added. And so I think it's too much to make a few minor edits tonight. I think it needs to come back and in the near future, in a much more detailed form. Is that specific enough?
Yeah, and I appreciate you sending those edits over through email and, so Joe, if you'd like to make a motion, I think the proper thing would be to make a motion to bring this back at an upcoming meeting, so that we can work with staff to.
I move that the cath lab quality assurance policy be brought back in the future after additional work and revision.
Can I get a second on that?
I'll second.
Can I ask a question before we?
Please, yeah.
Steve or Matt or staff in general, is there any procedural issues with MEC or hospital for delaying this? If it's more about what else do we want to add to it? Is it okay to have it wait?
No, we're a couple months ahead of schedule with this particular policy. I don't know, is there anything you want to say about the suggestions that were made?
No, and I
Thoughts on that?
I appreciate Dr. Gallagher's
Yeah.
review and his comments. Steve did share that with me. And so, this, for your awareness, this policy has gone through QPSC and MEC prior to coming to the board of directors and has had different hospitals physicians looking at it. But again, this is preemptive as we aren't open, as you know. And so I appreciate your suggestions and welcome the feedback. And I think that, we, we'll take it back and take your thoughts to paper and we'll get back to you.
Thank you very much.
Please.
I'll take roll for the vote on that item. Director Gallagher?
Yes.
Director Vonses?
Yes.
Director Pimentel?
Yes.
Director Cox? Yep. And Chair Nunez?
Yes. All right, moving on now to our discussion items, item number 4. This is the Medical Executive Committee report that we received in closed session. I do have to ask if there are any questions from the board for staff for this report before I open up for public comment.
No.
Okay, seeing none, I'll open up to public comment. Rosie, any raised hands online for item number 4?
Any raised hands online? No.
Anyone wishing to comment on item number 4? It's the Medical Executive Committee report. Seeing none, I'll close it down and I will entertain a motion to approve the MEC report for September 2024.
I'll move approval and with just the comment that I appreciate having all this information in the packet in advance. It's really helpful to be able to understand it before we come to the meeting. So I just appreciate the work and the quality of the reports are growing and growing. Just thank you to staff who are doing work behind the scenes, make it really easy to work with.
Yeah, thank you.
So I motion for approval.
Second?
Director Gallagher?
Yeah.
Director Vonses?
Yes.
Director Pimentel?
Yes.
Director Cox? Yeah. Chair Nunez?
Yes. We'll move on to item number 5, and that's the Chief Executive report. Steve, for your rec.
Yeah, thank you, Chair. We have the leadership report from myself, Naco and Phyllis. So go on and see if this works. It's on. There it is. Right. We mentioned already the Twilight Tapestry Gala, which was really a tremendous success. Thank you again to June and everybody who participated in helping with this event. The live auction raised $29,000. The Fund the Need initiative is going to enable the hospital to purchase 2 patient monitors for $20,000. Additional Fund the Need dollars were raised to support preventive care like colonoscopies and mammograms. We've just had positive comments flooding in. Lots of people are like, when is next year is going to happen? Because I want to come again. So just June and everybody else who participated and helped make this possible. All the board members who came, everybody in the public, thank you. It was wonderful. So on to our dashboard. So you'll recall the color coding that we have. Red is an opportunity for improvement. White means we're at baseline, green is our target for the year, and blue is at best practice. So here we are, 2 months in a row now with no red on the dashboard, so we're feeling really good about that. I will go through each quadrant individually as I tend to do. So HCAHPS, overall rating of the hospital, last month, you might recall this one was green. We were at 74.2%. It ticked down a little bit to 73.8%. Well, on the January dashboard, this was at 66.5%. So some really tremendous improvements in patient experience. And I'm going to show that in a second as I like to show some of the trends. Hospital acquired conditions, we are remaining at 21, which is at baseline. It's a big improvement from last year when we had 32. But we are at, our goal was to reduce it by 50% or more. So not quite at that 16 level for our annualized rate yet, but at 21 is still a really good improvement. HCAHPS, you're not gonna be able to read all the numbers at the bottom. That's okay. The things to look at here is the dotted green line, which is the trend line over the last 20 months. So this is from the beginning of 2023 to August of 2024. And I mean, 5 out of the last 6 months above the 75th percentile is pretty amazing and kind of jaw-dropping. And actually, so previous page, we saw 74.8 on the dashboard. So dashboards are a moment in time, right? So when I pulled the data on the dashboard about a week and a half ago, we were at 73.8%, which was baseline because not quite a target. When I pulled it this morning for this graph, we're at 75.2. So the additional 15 surveys that were added in the last 2 weeks were all really good and brought us up from 73.8 to 75.2, which is again like the highest we've been. However many months. For those in the audience who haven't seen this before, the number that we're talking about here, the 75.2%, that's the percent of patients who are inpatients who get a survey at home, who give us a 9 or a 10 on a scale from 0 to 10. So this is our moms who have delivered a baby, this is our patients who have had inpatient surgery, or this is our patients who are admitted through the emergency department, spent at least one night as an inpatient, went home and got a survey. And if they give us a 9 or a 10 on a scale from 0 to 10, that's what counts. So 75% of our patients who have been discharged in calendar year 2024 have given us a 9 or a 10. It's pretty awesome. It's above the 65th percentile. So we're around the 68th percentile, which means we're about better than about 65 to 68% of the other hospitals in the country. And yes, wow, I saw Carolyn say, wow. Thanks. I can read I can read lips when you say wow. That's really, yeah, it's really awesome. And it's a real credit to the staff and the providers. The clinical services and access quadrant of our dashboard, we are still green on patients served. So we've served more patients than in the outpatient side, everything non-emergency department outpatient than we did last year at this point, and then what we had budgeted. And for transfers from Watsonville to another facility, we're still at 2.4. That's where we were last month. It's a little bit better than 2.5% of our patients that we transferred out of the emergency department last year at this point. And again, that's an important metric for us because it is one indicator of, are we providing the specialty backup and access that we need to keep patients here? We're obviously not going to be able to turn this number to 0 because we're never going to be able to provide every single high level of care. But there are some levels of care that we ought to be able to provide in the community hospital that sometimes we don't have it because we don't have a gastroenterologist on call, or we don't have a urologist on call that particular night. So as we continue to build those services, we'll be able to keep more of our patients here and be able to take care of more people here in our community rather than having them need to be transferred to another facility. So that's why it's a key measure of success for us. One trend graph that I have here on patient served for outpatient procedures. Again, this is essentially all outpatients that are not the emergency department. This is the monthly trend for that 37,000 patients that we've seen so far this year. So you can see a pretty nice upward trend, a little bit down in August from July, but still at a higher level than when we started the year out. And then for transfers, we were increasing our number of transfers 3 months in a row, but in August it went down. So I've got two different lines here. I presented this one last month too. The total number of actual transfers went from 97 last month to 62 in August. We also have this pediatric psych program that we are partnering with the county on. And if we took those patients out, those patients who would have gone to Dominican because they're North or Mid-County kids who came here instead, and then we transferred them out to a psychiatric facility after being here, that would have there were 13 of those in August, and so that would have been 49 total transfers had we not done that program. So hopefully that makes sense. Talent and culture, so staff retention, we're at 78%. This ticked down a little bit from last month where we were at 79%. This is still right around the national median for staff retention in hospitals. So not much of a change there, still better than where we were last year, but not quite at our target yet. And then financial sustainability, obviously Julie will go through this in much more detail, but we did have a positive financial month in August. We're still at a loss for the year to date. So we're at about a $1.4 million loss year to date, which is much better than our budget, which was a $3.3 million loss at this point, and significantly better than where we were at this point last year, when we were over a $10.5 million loss at this point last year. So over a $9 million improvement in the first 8 months of the year. Seems pretty good to me. So congrats to the team on all the successes there. This is the trend graph that we look at in our linked metrics room for operating income on a monthly basis. So these are just the numbers that show up on that dashboard month over month, so you can see. And then on the far right, it's the year to date. When you add this all up together, you get the $1.355 million. Okay, any questions on the dashboard from the board? Do I talk about this one? Other topics? So
Just not a question. I do want to give you that reaction of wow.
okay.
Like I've been wowed through the whole thing, and it's hard to process. Like this is us. Like I see the work, I see the staff, and I see what everybody's doing.
Yeah.
I'm not shocked, but it's still so grateful to see how fast it's come around. So I don't want to ever lose a moment for now. I want to keep remembering that this is a wow. These are all wow.
Yeah.
So just thank you.
Yeah.
Thank you for everybody. Please.
Yeah, the team's working
Yeah.
really hard, but it's doing a great job. Really appreciate it. Okay, so other topics, seismic compliance. So this may have popped up on your radar if you read healthcare news like I do. There was a Senate bill this year, 1432, which was called the Seismic Standards for Health Facilities. The background is that there were strict seismic standards for hospitals that were created back in the 90s with a 2030 deadline. SB 1432 would have extended that deadline to 2035 under certain criteria for hospitals. It went through committees at the state level. The Assembly passed it 56-0. The Senate passed it 31-0, and Governor Newsom vetoed it. I didn't read his reasoning for why, but here we are. I would assume that one reason is the hospitals around the state have had 40 years to work on this, and they've chosen not to for whatever reason, financial or otherwise, to get their buildings in seismic compliance for 2030. The upshot for us is that this doesn't impact us because we are already seismically compliant to the 2030 standards. And so this next slide is just, if for your curiosity, this is publicly available data on the HCI website at the state. SPC is the seismic performance category, and it's on a scale from 1 to 5, 1 being not seismically compliant, 5 being fully seismically compliant. So we are one of the hospitals in 5 categories. So we are fully compliant on the SPC rating. And you can see, I just pulled the hospitals from like a 4-county radius so that you could see them and who they are and where they are.
So if our name started with an A, we'd be on top of the list.
This is alphabetical. I'll do reverse alphabetical next time. Yes,
That's cool.
That's a lot.
Thank you, John.
yeah, right, indeed. All right, I'm happy to take questions, and I know Matco and Phyllis have reports as well.
Any questions before we go to Matco's report?
No, thank you.
No, same, Matt?
Yeah, thank you. Just a couple of things to touch on today. On the physician front, our USACS hospitalist group has is onboarding a new medical director. So Dr. Benson Samuel has accepted the position and will be starting late November as medical director. We had an opportunity to interview him. Phyllis and I did. He was a very impressive candidate, extensive background, education history. So we're excited to have him on board with that USACS group. On the facilities front, we are working on a telephone conversion. So, people don't often think about telephones unless they're not working. Ours are working, thankfully, but AT&T is phasing out copper. So they're really pushing everybody to just a newer standard. And they're going to continue to increase rates to encourage people to move on. So we are working on converting to SIP, which is just voice over internet, essentially. So we are going to be working on that and hopefully converting very soon here, which is going to lead to a significant cost savings for us as well. So we've confidence in the voice over internet is increased significantly. So we're feeling comfortable that's going to be the right decision for us. More to come on that. Just a quick Nourish update also. So Second Harvest is now a diaper bank as well. And so we will be distributing diapers through our Nourish program for local people that are in need. And just a rough estimate, it's about $1,000 a year to keep your kids in diapers, as Tony can probably attest to. So this is a great thing for our community and for the patients that are really in need and having to make decisions. We'll have to make one less decision now. So that's a great thing. Steve mentioned the gala event, nothing but positive comments from everybody. So thank you all that attended. And on the foundation front, Tricia Gardner is almost done with her interviews for the strategic planning session that is scheduled for November 1st. That's it for me today. Any questions?
Any questions?
Nope.
Okay, so a couple of updates from the last time I was here. For pediatric admissions, I reported last month that we had a hold on pediatric admissions. I'm super happy to say that as of September 15, we are now able to admit 14 years and older. So patients who need surgical intervention, we've been tracking very closely how many patients we've been transferring. It was about 8. So we are now able to admit patients ages 14 and over, based on Title 22 and CDPH guidance. So that is now in effect. We are still not able to admit patients 13 and younger. However, working with our Stanford pediatricians and our nursing teams to develop a long-term pediatric service line strategy. So very excited about that work and really happy with that partnership. So I will continue to bring those updates to this committee. Secondarily, nursing education, speaking of Stanford, the Stanford neonatal resuscitation team was here doing something called Stanford Revive. It is a higher level initiative for enhancing resuscitation. It's in the emergency department. We had our NICU nurses come down, and pediatric emergencies requiring resuscitation are very high stress. So we did some simulation work. We had our physicians and our nurses. It was very exciting, and it really showed the wonderful relationship we have with the Stanford team. So really appreciate them reaching out and providing education to our teams. They didn't have to leave to have it done. We are doing ED skills days in early October, as we've been doing throughout the hospital, reinforcing nursing practice and really building on team building. We are working also with our charge nurses on skill building and leadership training. So that is in progress. And I wouldn't be doing my job if I didn't talk to you about fall flu vaccines and COVID vaccines. So I'm here to say that we are now vaccinating our staff in the hospital. We start our flu clinics this week. I would encourage all of you to get your vaccines. They're readily available. If you go to, I have the website here, myturn.ca.gov, you can find out where, and I just a quick search within 10 miles of this hospital. There's like 15 places you can get flu vaccines. You can get your flu vaccine and your COVID booster at the same time. The CDC is recommending that, especially if variants continue to travel around. And once again, the federal government is providing 4 free COVID tests to every household. you can go to covidtest.gov and you can have them mail those to your house. Everybody can get COVID tests for their home for free, starting at the end of September. So get your vaccines. That's the end of my report.
Thank you so much. Any questions? I do have to open it up to public comment. Rosie, any raised hands online for either of those updates?
No hands raised online.
Okay, any person wishing to speak? No? Okay, I'll close that down and we'll move on to item number 6, the Chief Financial Officer monthly financial performance. Julie, you guys are ready?
Okay, so as Steve mentioned, we had a good month, and are doing. We did, have a couple of, items that stood out. Family supply expenses being higher. We noticed that kind of in the robotics as we continue to do more robotics cases and also some stuff in lab reagents. This was the month that we also accrued for the county election fees. Even though the election was 9 months or 6 months ago, it takes a while to get those invoices, track them down. And so we did do some accruals for that. And we did some property tax true ups because our property, or not property tax, property insurance. Our property insurance, which currently is purchased through MPT, actually went down this year after a significant increase next year. So that was kind of nice to be able to true up how we're accruing for that. Next slide, please. So on a year-to-date basis, as Steve pointed out, we have a $1.35 million loss. On the EBITDA, we're actually a favorable 1.67 million through 8 months. EBITDA, we had budgeted at about 365,000 for the year. So we are well ahead of budget, as you can see. Okay, this was just a slide I introduced last month. The blue bars being expenses, the green line being net revenue, just to show you that when the blue bar goes higher than the green line, it means we're spending more than we're making. And so the good news was in August, after a couple months of spending more than we were making, we got back to the right side of that equation. Admissions were up in the month. We were at 309 admissions in August, so we were up about 22% from July and higher than this time last year. You can see just, a slight kind of trend line down of a decrease, but as we've talked in the prior meetings, that really is related to us being better at identifying observation, which is an outpatient visit versus an inpatient admission. Next slide. So here's when you put together the admissions and observations, there's a slight year-over-year increase. And it does vary by month. The month of August, we actually had a little bit fewer observations than we had in July and a lot more admissions. Deliveries, they were up a little bit this month, so 62 for the month of August. Last August we had kind of a gangbuster month, so last August was a little bit unusual. Generally with the deliveries running in the 60 to 70 per month, so 62 kind of falls right in our average. Average daily census, we were at 32.8 days for the month, a little bit up from July, and currently we're running just short of that for September. So we'll see if we can just catch up, but right now we're a couple of points below that. Acuity went down this month, so even though we had more admissions, our patients just tended to be less acute. We kind of noticed that mostly in kind of just, general medicine, folks that end up on med surge, some GI cases, neurology, things that were just not as acute this month. So, even though we had more admissions, they just were not the same. On the outpatient side, fairly normal month. We did, in our non-emergency room, we did see about a 14% non-emergency visits, outpatient. We did see about a 14% increase, with the largest part of that increase coming in the outpatient imaging. We were up about 22% there. On the ED visits, this just, the 86 in blue just shows those that were not admitted. When you actually include ED visits that were admitted, we averaged about 93 patients per day. On the surgery, so we had 46 inpatient surgeries, pretty much in line, a little bit up from where we were the last couple of months. We were at 127 outpatient surgeries, so a little bit down on outpatient, very strong with the 23 robotic cases. The outpatient surgery, we did actually see some increases in GI and general surgery. It was just offset by some other areas where we didn't have any cases. Here's what the outpatient looks like, and pretty much what this just shows is the top three continue to be the top three. So general surgery, OB/GYN, and ortho are the most common surgeries we're doing here. The yellowish at the bottom, which is GI, and has come in fourth place. It was up a bit in August. From a payer mix, this inpatient payer mix, good. For the commercial, we were up at 18.8%, so really our highest month in the last 13 months. We saw also an uptick in the managed Medicare, which is first time in a while that I've seen us up over 10%. We were at 11.7. Whenever something goes up, something else has to go down. So we really saw the largest decreases in Medicare. We're just at about 24% there. And in our managed Medi-Cal or our Alliance, which is still at 38%, a healthy 38. And then finally, on the outpatient side, pretty stable. I mean, really, there's not really anything significant to talk about here. It stayed pretty much where it always is at. Probably the good news is that we had one of our lower months in terms of true self-pay patients. I'll take any questions.
Any questions for Julie before I open it up to the public for comment? No? Rosie, any raised hands online?
Don't have the line.
Anyone wishing to speak on this item? Or no? Any comments from the board before we move on? Oh, thank you. Just one comment, just the month over month and then the year to date, I keep looking at that lease payment and thought that lease payment, we'd be making money on that lease payment. So can't wait to get it out from underneath that and take that next step. That's gonna be really big for us. So, but thank you, Julie.
And I'm gonna pop your bubble. I just have something. I mean, yes, it's good news, and I've never been so happy to see a red number before. It's a smaller red number, but it's still red. And we're still not funding a lot of things the way we should, especially our facilities. We're not investing in our facilities, and the bond can help certain parts, but we still have to fund maintenance and improvements ourselves. So look forward to the budget to show us some of those gaps that we'll get to.
Julie, whenever you're ready.
Okay. Well, that was a perfect lead in. Both comments actually very appropriate to talking about our budget. So this month, this is just a budget update. I hope to be actually maybe bringing some numbers to the next budget meeting or the next board meeting. What I will point out, we've just talked about what our year-to-date performance is. And, if I just annualize where we left off in August, we'd make about $2.5 million worth of EBITDA. We'd probably lose about $2 million overall. And, that's quite an accomplishment, as we've said, versus where we ended 2023 with a $13 million loss. So in order to get to the point where we're funding projects and maintenance and things, we are targeting to have about a $5 million EBITDA budget. So you can see that's a shift and a swing. And it's gonna take us some work to get there. It's part of the reason that kind of putting numbers out in front of you, it's a little premature yet. We are just kind of drilling down into everything. We're building each year since, the beginning of our new company, we've kind of built more and more rigor around how we create the budget. We've had to build for ourselves the data. The data sources were out there, but when you talk about being data rich and information poor, that was kind of where we started. The last year we were able to bring it along so that we could do detailed, we could do department level budgets. First year, we didn't do department level, we just did a hospital wide. This year, we're even deeper into the detail, and I'm just gonna give you a couple of highlights in the next couple slides. But, the hope is that when I come back here on October 30th, you can see kind of how our work is progressing towards a $5 million EBITDA. So, on the revenue side, this year, we have actually had, I won't call it the luxury because it took a lot of heavy lifting to build it, but the luxury of kind of really being able to drill into our charge master, look at prices, down at the lowest level of detail, not only by department, but, sometimes by level charges. And we've also been looking at comparing ourselves to our most, closest competitors. We look at our contracts to see, what are they paying on and what does it matter? It doesn't matter what we charge, they're only gonna pay what they're gonna pay. And of course, with government payers, they're only gonna pay what they're gonna pay. So we're very reliant on a smaller portion of our business that actually will give us year-over-year rate increases. But we really came to the point where we actually determined that we do need an increase in the number of departments, and it does run from an average of about 2.75 up to a couple of them being around 7.5%. But we also have some decreases in there. And so when you lump it all together, it really works out to about a 2.3% decrease in our charge master. Now that might alarm you until you really kind of dig into what it takes to come up with the net revenue, and realizing that if we charge something that payers aren't going to pay, we're writing more of it off. So really what we're doing is we're skimming off some of the write-off so that we still can kind of get paid what the payers are going to pay, but also remain competitive with our nearest neighbors. We are, kind of anticipating that through charge increases that are built into our contracts or any kind of market basket increases, we do think that we should be able to get about 0.5% of a net revenue boost on the charge sensitive type of accounts. And, we will always have revenue cycle improvement projects and working to make sure we're collecting as much as we can, eliminating or reducing denials, timely billing, timely charging, everything that goes into having a strong revenue program. Now this year, we've been doing the hospital quality assurance fees. We are on Quaff 8, and it started this year and it continues into next year. And right now with the known schedule that we have, there's about $13 million of revenue that will come from that. So that's net of the fees we pay. But there's also a Quaff 9 program on the horizon. That's good news, it's on the horizon. The bad news is we really know very little about it. It's not, the details aren't out yet. They probably won't be out until later in this year or the first quarter. It probably won't even be approved till middle of next year. And hopefully some of it will start towards the last quarter of next year. But I don't yet know kind of what I'm going to bake in there. I'm going to keep waiting till almost point of closing the budget to hopefully get a little bit of the rumor mill or some details on what we can budget around clock. The other is, the the disproportionate share. We get that now. There's a lot of rumors about a 50% cut that's gonna take place. It's more than a rumor. I mean, it's said to have happened, that's going to happen, but it's been postponed many times in the past. So we can keep our fingers crossed that maybe it'll get another postponement, because a 50% cut to our dish payments would hurt. Bad debt, for the first time in the last 2 years at least, we have a collection agency contract that basically helps us try to collect on anything before we write it off to bad debt and just, call it uncollectible. We already send self-pay and self-pay after insurance, accounts to what we call an early out vendor or self-pay vendor. They work them for about 150 days. If they're not able to contact the patient or make up payment arrangements, then they return the accounts, and that used to be the end of it. They just, okay, well, they're just gonna sit. Now we have another vendor that will come in and make some other efforts and try to collect. Nothing, we're not harassing people. It's a pretty, patient-friendly collection process, but, it does provide some success. And so we have that in place now. And then we think other revenue will be generally pretty flat to what it is now. Next slide. From a volume and payer mix, I really just brought back some information that I had shared at the last budget update. We've got some, conservative volume growth, really. The largest increases are going to be in surgery, which includes the cath lab and bringing on, hopefully 400 new cases with the cath lab. On the payer mix side, this is just, trying to see where, we've started to see some improvements in payer mix. Sometimes they slide a little bit month over month, but these all feel pretty achievable. And it's amazing how just a couple of percentage points can add a couple $100,000 to $1 million to your net revenue. Next slide. On the expense side, we slice and dice and look at everything we can think of to, try to be as accurate as possible with expenses. We look at different things depending on the type of expense. Sometimes we're looking at an expense per unit of service because things are very volume driven. Sometimes it's just like it's a fixed rate. We know we have a contract in place. Or sometimes we have to say, well, the best information we have, something like utilities, is to look at a rolling 12 months, pick up the seasonality, try to understand what might be happening in the market with rates. Sometimes we're just looking at what we spent year to date and annualizing it and saying that's probably about where it's going to fall. We will add inflation factor and try to search the market to understand inflation. It varies from kind of area to area. So we add the inflation factors. So volume and inflation factors and these various methodologies bring us mostly to our expense budget. We also spend a lot of time looking at department productivity, overtime, double time, making sure we're being as efficient as possible with our expenditures. So as you can imagine, going from, losing 13 million last year, hopefully coming pretty close to break even, maybe $2 million loss this year, all the way to $5 million for the even the next year. We got to have some initiatives. This is the starting list. This won't be everything, but some of the things that we are definitely, involved in. Trying to calculate, trying to have the most solid projections is our cath lab. Cath lab, we've kind of done a range because it really is going to depend on when we open, what the payer mix looks like, how fast we can ramp that up. We're, sometimes looking at potential pediatric volume, labor productivity, and especially the premium pay, the overtime double time, which is just a very expensive way to deliver the services. We look at our abilities to impact that. We have been doing a lot of work with our group purchasing organization, trying to get our arms around. Now that we have our data and their database, where are our opportunities to improve contract rates or, look at supplies and that we're in the right tiers. So there's some savings there. As we've mentioned, purchasing the property, it makes a nice dent in that gap. And we have a new primary care physician. Usually when you bring in physicians, that's just looking at, the cost of the physician and staffing their clinic to revenue doesn't necessarily make money. This shows about a $250,000 loss. But what we haven't really gathered yet is it brings in new volume. They start to refer some of their services, even some stuff they've done in their offices might come to the hospital, as well as they start to refer to our specialists. So it opens up a great opportunity, and it's going to be such a huge win for us to have a primary care physician and then to start growing the primary care business. We've got a LED light replacement savings project that's going to reap us some money. And then I just added to my own copy here, the telephone conversion that Matt was mentioning. I've already asked him when and how much. So we will continue to chase those sorts of things down and hopefully come back next month with more concrete data about how it's looking.
Fantastic. Any questions for Julie before I open up for public comment? All right, seeing none. Rosie, any raised hands online?
No, the right hand online.
Anyone wishing to comment on Julie's budget, please?
I may have missed this, but I have a relative that's in middle management at Salinas Valley. She said that they had a meeting and they were told that Kaiser is opening a 10 to 12 bed outpatient facility in Salinas. And they were told that they were going to be referring all their surgical patients from that facility to Watsonville. I was wondering, is that rumor? Is that true? I think potential to make some money there.
Well, there would definitely be the potential to make some money, and it's, we have a very strong relationship with Kaiser, and, we are aware of the facility. I think it's open in January 25, and, they have talked about sending business our way.
Thanks for answering, Julie. Please, you a public comment or?
Yeah,
Please.
Hi, I'm Greg Boney, work in surgery. I drive in from San Juan to come to work here, and I've been hearing the advertisement about the Kaiser coming to, to Salinas. And I'm just curious that we haven't really looked into how many patients we might get, how many surgeries we might get. I mean, we're waiting until the ball drops and we're gonna work on it. Or are we started talking, negotiating with Kaiser to see what they might bring to us? Because if we bring more people, we're gonna need more patients, we need more help or more whatever. More product, more, everything. So I'm just curious that we haven't been on track to find out what they're gonna do, what their plans are. So we're gonna wait till they open and we're gonna get caught behind the 8 ball to catch up to them. Is that what we're saying?
No, that's not what we're saying.
And I
We
appreciate,
are having.
But we haven't talked to them. We don't
Yeah,
know.
Conversations, we meet with Kaiser.
Oh, okay. So we'll get that information in the future.
So this is public comment, and typical, like, to not, for us to answer questions, it's just for you to give comments, and then,
Okay.
and then,
I think we should be ahead of the ballgame so we can capture as much as we can. Thank you.
Definitely,
Yeah.
thank you.
thank you.
Okay, any other public comments? Anyone else wishing to speak on this? No. Okay, thanks, Julie. And, yeah, please.
In clarification. Always starting with appreciation for all the work that we're doing. You opened up with the projection that we might have, there's one model projects a $5 million positive EBITDA. But below EBITDA, that's not the bottom line. There are other costs down there. Last year, our other costs were almost $6 million. So even with the 5 million, if we hit 5 million, we still might lose $1 million consolidated with everything together.
Well, what's below the line is your $3 million lease
Correct.
payment. But there's also, we book more than the cash that goes out the door below the line
Yeah.
for the MPT purchase. That's just the way the lease arrangement is. So most of what you see down below the line is related to the MPT. Last year we had also budgeted the associated insurance that MPT gets for us below the line, but we've actually been reporting the expense above the line and tried to get it moved up there for this year's budgeting, so it's an above the line expense. So really what's left below the line will be depreciation, which is much
Yeah.
less than that
Yeah,
full amount.
great, thank you.
Okay. Any other comments before we move on to item number 8? Okay, so item number 8 is Bar Valley Healthcare District Hospital Corporation Quality and Patient Safety Committee update and member appointments. Steve, this is from you.
Yeah, so we're gonna receive and file the quality and patient safety Q2 update. And I think that Phyllis is gonna go through that, yes.
Yeah.
And then we will have ask for a motion approving Michael Hamme, our interim risk and quality director, and Phyllis Stark, our chief nursing officer, to serve on the QPS committee of the board, and appointing Director Gallagher as the committee chair. So I think we can probably go through the presentation first, and we can do that motion if please support. Phyllis.
Thank you. Steve, can we go to the next? Sure. So going through some of the slides that we discussed at our quality meeting. So you'll see on the left description of the leapfrog survey. I think we brought those results here, but just wanted to refresh everyone's memory that this is a voluntary, consumer-driven database where we are compared across the country to facilities. And so these are quality scores, and every year they change a little bit. And we bring that here to this body for review, and it only reports the data that we voluntarily give them. But it is in our best interest, of course, to cooperate, because this is something that is publicly reported, and it's very important that we submit our data, and we do. Our safety grades are assigned for many different things for many resources. It includes data from CMS and the survey that we submit. Next slide, thank you. So our 2024 results are now available. We have seven measures demonstrating a change from previous scoring, 6 measures demonstrated improvement, 1 measure demonstrated decreased performance. And the challenging areas that we have are hospital-acquired conditions. C. diff is something that we have, I'm happy to say, since March of 2024, May of 2024, we have had no C. diff reports, but this is something, 13-month reporting rolling period. So it's very challenging, although we have gone many months without a C. diff, this will continue to be reported until that falls off. So it is in our best interest to work these cases. And Michael, as our infection preventionist and now interim quality leader, is taking point on that. And ICU staffing is just another model that we are struggling with, only because of our very low census. So let's go to the next slide, please. Oh goodness, this is a definite eye chart. So I will just give you high level on the left side, because I can mostly read all of that. So some of the PI opportunities we have. So there was a requirement, it's relatively new, that all hospitals report BSN or higher prepared nurses. So in our own data system, we were very hampered in being able to adequately pull this. So we ended up having to call people, survey people, do survey monkey, all the things. We have changed our practices so that now within our hiring process, we are identifying the education level so that we have, I think, more reliable reporting going forward. So this is was because we had such difficulty reporting it. We scored a little low, and so that is a PI opportunity for us, and we've taken that challenge on. Med reconciliation in patient, there's a requirement that, and very important safety requirement, that we are reconciling patients' home meds with their hospital meds and making sure we're discharging them properly. BCMA is barcode medication administration, where you use little barcoding, make sure you're giving the right patient the right medication at the right time. MedRec outpatient is similar, but this happens in the ED and in our outpatient surgery environment. I've talked about C. diff, pediatric radiation dosing. This is very specific of dosing by modality. And so it's looking at working with best practices, working with our leader Nellie and MACCO to ensure that we are using the minimum amount of radiation for pediatric studies that we need to get the studies, the quality that we need them to be. A little complicated. Preventing blood clots post C-section. So this goes to being sure that we are following all of the evidence-based practices as a post-surgery patient. C-sections are making sure that we are using the sequential stockings, making sure we are addressing hypocoagulation. Bariatric, sorry, procedure volume. So our volumes are very low. Many of the things on Leapfrog that are procedures are volume based. So we have a very low percentage of bariatric procedures. That's why this shows us the PI opportunity. And read the last one. All of our outpatient surgery, patient satisfaction. Thank you. So this is something that we just started reporting this year, correct? Yeah, so we are working on improving those scores and the return rate of those scores. Okay. Next up. So we are actually having survey preparedness meetings, and not just for Leapfrog, but looking at Joint Commission, CDPH, any agency that could come in here, and I'm really happy that we have started those meetings. We have subgroups working on all of these things. The Peri-Op team is working on outpatient patient satisfaction scores. In our perinatal services, we are looking at DVT prevention for our post C-section patients. Radiology is working on the pediatric radiation exposure, as I mentioned, and reconciliation is happening everywhere because this is something that is important to both our inpatients and our outpatients. God bless you. So Leapfrog safety grade update. So right now we are in this they're calling it the fall courtesy review period. So we are able to look at them, but we are not publicly reporting them. Tuesday, October 1st, there is a town hall, which we will be attending, talking about how you roll these out to your community and to your hospitals. And in November, that is the embargo period, very interesting name, looking at how we analyze the data so that we can get to fall public announcement, which is in November. And the embargo period means we know, but we can't tell anybody. So, next slide. Okay, so turning our attention to readmissions, you will see on the far right how we compare in California hospitals, and our readmission rate is very low, thankfully so, but still every readmission is an opportunity. So we review all of the readmission data and look for opportunities to determine, are they avoidable or are they not avoidable? Next slide. Hospital acquired conditions. So the numbers up below, Michael, make sure I keep me honest here. The numbers below are how many days since the last of these occurrences. So this does not mean falls equals 30. That would be alarming. No, you do not have 30 falls. I am sad to say that we had 2 falls this week. We are drilling down and really managing those. There are falls with minor injury, but still alarming nonetheless. So we take these very serious. The HAPIs, these are hospital acquired pressure injuries. We've had 178 days, so this is very good. This is the diligence of both our nursing teams, physician teams, as well as we have an amazing wound care team here. Hospital acquired infections, and it's been 39 days. Those reminding you, those are urinary tract infections, surgical site infections, and C. diff. And then SSIs, it has been 5 days since we had a reported SSI. This is the C. diff rate. I mentioned that this has a long tail because again, rolling 12 or 13 months. So our goal is obviously less than 0. And because of our previous higher numbers, even though we are since May without one, it's going to take a while for this to fall off. There you go. Any questions?
Any questions before we open up for public comment?
Wait, I do have a question.
Please.
The town hall, that's with Leapfrog people. I assume this is the organization that gets on this phone call. Thanks.
Okay, Roseanne, you raised hands.
Okay,
Anyone in the public wishing to speak? No. So with that, we'll receive and file that report, and we're looking for a motion to appoint the Michael Haim and Phyllis Stark, and also as members of the Quality and Patient Safety Committee, and also appoint Director Gallagher as the committee chair. So move.
Second.
Director Gallagher?
Yeah.
Director Bonner?
Yes.
Director Pimentel?
Thank you, Joe. Yes.
Director.
Yes. Okay, so I will adjourn the meeting for the hospital corporation